So good morning, everybody. We're delighted to have you here and to have our wonderful team of panelists. My name is Dr. Snow. I am a counselor with Beyond Healing and also a professor at Governor State University where I teach counseling. And I'm also very proud to be a member of the Homework community and a member of the Behavioral Health and Mental Health Committee. So we're going to start with just having everybody introduce themselves and maybe just talk for about 5 minutes of who you are and what services you provide, so that everybody, in the panel, in the audience, can get a sense of the panel that we have up here. So, Tracy, would you mind starting, and then we can just kind of go around.
I have kind of a big mouth, so I don't know if I need the microphone or not. My name is Tracy Curtis. I am the Community Education and Outreach Coordinator at the Crisis Center for South Suburbia in Tinley Park. We help those that are enduring domestic abuse. So we have several programs. I'm in the prevention program. I go out to the community. I work with professionals. I'm getting to work with Dr. Snow at GSU. I'm out there quite a bit through the counseling department as well, just to help the students. Obviously, education is our best tool for prevention for domestic abuse. So I kind of just go anywhere and everywhere. Our other component of prevention is what we call our Safe Start program. And it is the girls, our coordinators, go into the schools, our curriculums for grades 7 through 12th. So they're speaking with all the middle school and high school students. On top of that, we have counseling. All of our services are free for anyone that is enduring domestic abuse, even if you have been touched by it just as a family member, friend that's trying to support a survivor. We can definitely take you as well if we need the support. You need the support for counseling. We also have a 24/7 hotline number and an emergency shelter. So if anyone is in imminent danger, we can definitely try and get them into our shelter. If our shelter is full, which it can be a lot of times because domestic abuse is still pretty prevalent, then we will help them, assist them get into another area shelter as well. But on top of that, we do have 2 resale stores, Neat Repeats in Orland and Worth, and those are 2 very important components for the business because all the sales for that do funnel right back into the programs for the DV survivors.
And would you mind just telling us a little bit of what is encompassed in domestic violence? Because there's so many different pieces to it.
Absolutely. So domestic abuse, I know we are finally getting to the point in 2025 that when we talk about domestic abuse, we know it's not just that physical abuse. Physical and sexual abuse are the 2 forms of abuse that we criminalize in the United States. Unfortunately, that really actually encompasses a very small part of what domestic abuse is. It's all the other tactics that take form to threaten, intimidate, harass, whatever that may be, and we can break it down into emotional, psychological. Basically what it is tactics called coercive control. And that is all the tactics that really do hold the victim in the relationship because she is so beat down by the abuser and she's scared to leave, and that's what causes that average of 7 to 9 times leaving and coming back. We obviously try and prevent that because each time she comes back, he's generally going to have to amp up the abuse then to get her back into compliance, to get her to stay. I said she is a victim, he as the abuser. By all means, we are one of the 7 shelters in Illinois that do accept male victims as well. So we just kind of try and keep females and males separated a little bit so there's no triggering there, so that's just a general statement. We do accept male victims because domestic abuse does impact male victims as well. The national statistic is 1 in 3 women, 1 in 4 men will be physically abused by an intimate partner. That 1 in 4 men is probably closer to 1 in 3 because men underreport for obvious reasons. They feel as though that they don't need the support, that they can just go ahead and manage. So we encourage them to reach out to us for support as well. Statistics, again, come from the physical abuse because that's what we criminalize and that's what we can measure. So if we kind of look at those statistics, you can really start to think of what actually goes on in an abusive relationship. The physical and sexual that we do prosecute in the United States only makes up about 2 to 5% of actual domestic abuse cases. So we really are missing the vast majority of cases, and the impact from the coercive control is what brings that long-term impact to the survivor.
Thank you so much, Tracy. You're welcome. Erin?
Hello, I'm Erin. I am from Beyond Acceptance, and we are a branch of Beyond Healing, but we're focused on LGBTQ plus individuals. So we work with individuals about age 14 and up, and we focus on giving support for queer clients, trans clients, because there is a lack of care in the south suburbs for this population. And right now, there is such a need for it. The suicide rates for queer youth are much higher than the national average for non-queer youth, and in particular for gender nonconforming and trans youth. So to have these services in the south suburbs is life-saving. So we do important work, and we use multiple modalities. I tend to use quite a bit of psychoeducation, particularly with parents, to help them understand and learn more about their child, as well as providing information and resources about medical transition, social transition, as well as using other forms of therapy besides traditional talk therapy, such as some somatic therapy techniques. So a lot of times trauma is held in the body, and speaking about it, while it can be useful, sometimes we need to go a little bit deeper. And utilizing somatic approaches, meaning the body, through practices such as mindful body awareness, noticing when triggers come up, feeling where they are in the body, and allowing the body to move fully through the somatic arousal cycle, like fight or flight. I'm sure many of you have heard of fight or flight. That's the nervous system arousal when we feel fear. We can have fight, flight, fawn, and freeze. So our body goes into multiple different reactions, and we tend to get stuck in them because we suppress them. And with the high percentage of trauma that we see in the community as a whole, this is an important part of therapy. I also see clients that are in non-traditional relationships, such as open relationships, consensual non-monogamy, clients that are in the BDSM and kink communities, which can be a very important and healing part of their lifestyle. And as a whole, there's kind of a knowledge gap for therapists in that community. So to be able to provide educated counseling for those communities as well is a significant part of what we do.
Thank you, Erin. And one of the things I really love about that too is we don't just work with the individuals, but with the families too, because
Yeah.
a lot of times it's the family that all need to adjust to the changes and
Absolutely.
get that acceptance.
Yes. One of my favorite things is being able to work with parents and advocate for the child and help the parent process what they're going through
Yeah.
outside of what the client is going through, and being able to be that advocate and that guiding hand.
Thank you so much.
Yeah, thank you.
Maria?
Hello, my name is Maria. I work at Symmetry Recovery. We are a harm reduction clinic that offers medication-assisted treatments. So with that, we offer methadone, buprenorphine. We also offer IOP groups that meet 3 times a week for 3 hours each, 3 times a week for 3 hours each week. We offer an outpatient group, which is once a week, and then we also offer something called Smart Recovery. If you've not heard of Smart Recovery, I would highly encourage you to look it up. They are a psychoeducational group that is either harm reduction or abstinence-based, and it just kind of helps the individual kind of learn some of these skills on how to work on their chosen path of recovery. And I say chosen path of recovery because sometimes you have a client who wants to do harm reduction where they want to use occasionally, or instead of using cocaine, they want to smoke marijuana. Instead of drinking 4 times a week, they choose to drink 1 time a week. And then there's also abstinence-based, where individuals choose not to engage in any type of substance use. So at the Joliet location where I work at, we actually do a hybrid Smart Recovery, so you could do in-person, virtual, completely up to you. Symetria within our Illinois state, we have 6 clinics. So Joliet, Palos Heights, Lakeview, Des Plaines, Vernon Hills, and Naperville. Smart Recovery is completely free. There's also a family and friends Smart Recovery group that individuals can come to. In addition, because I am a workaholic, I actually also work at Beyond Healing, and I am slowly getting, with Dr. Snow's help, slowly getting Beyond Recovery up and running. So Beyond Recovery is going to be our substance use addiction components to Beyond Healing. There is a lot of stigma within families, communities, even states regarding substance use. A lot of clients I run into, they don't want to talk to their family and friends. I have a client who, I believe he's 19, who I work at Symetria. His family doesn't even know he's in recovery, that he's actively coming to a clinic once a week to get medication that is helping him stay in his recovery. Finally, he actually did tell his mom, and his mom goes, "Why didn't you tell me sooner? I could have been there to help you and support you through this." And he goes, "I was afraid of what you were gonna say." That is so sad to hear when we have a young client who's coming in to getting help and they can't share it with their friends and family because of that fear of they're gonna be called an addict, they're gonna be called dirty, they're gonna be told that they're a horrible human being because they have a brain disease. We often, within the substance use world, relate it to an individual who's diabetic. You have to take insulin, you have to take metformin to be healthy. It's the same thing with substance use. Buprenorphine, Suboxone, methadone is just another medication to help someone be the better version of who they are. With Beyond Recovery, one of our goals is we're gonna be doing DUI assessments. Dr. Snow and I both went through the training, so we are able to kind of like add that little sparkle to Beyond Healing.
Thank you, Maria. And one of the things that we often see with substance abuse too is it's typically tied to like trauma and shame and everything else. So it's important when we do work with substance abuse to address the mental health issues as well as the substance abuse because they are interconnected.
Yeah, the majority of clients that I see at my full-time job, and even the clients who are substance use or addiction at Beyond Healing, there's other diagnoses, whether it's anxiety, trauma, PTSD, depression. A lot of times clients use substances to be able to self-medicate, so they don't have to feel those dark and scary feelings. Instead, they can almost numb themselves. However, the problem is when you continue to numb yourself, you're adding to that little part of your brain that's that addiction thing that just doesn't want to let go and doesn't want to help the person. So you get a lot of the negative self-talk of, this is who you're going to be the rest of your life. You're not going to be any better. You're just going to always be an addict.
Thank you so much, Maria. Melissa?
Hi, my name is Melissa Howard. I am a licensed professional music therapist and a licensed professional counselor. So I'll just tell you a little bit about music therapy first, and then I mainly work out of Beyond Play at Beyond Healing. And so then I'll tell you a little bit about Beyond Play and what we have to offer there and the services. So with music therapy, I've worked with people across the lifespan, starting in the neonatal intensive care unit to a bulk of my work being in senior wellness and dementia care and everything in between. And so just simply, I guess, simple definition of music therapy is we use music to help with non-musical goals. So the goal could be to gain coping skills. It could be to increase community engagement. It could be decrease anxiety or pain. I've worked in hospice care where we're working on decreasing pain. So depending on where you're at and what your goals are, I would create a music intervention to help you reach that goal. So a lot of what I do at Beyond Play is gaining coping skills, dialectical behavioral music therapy, so using music to work on mindfulness, to work on emotional regulation, and what that can look like is playing instruments, an improv session. It could be picking out songs that are meaningful to you and creating a playlist together. So the music itself is therapeutic. We all know music is therapeutic, but in music therapy, it's the work that's being done with the music. So the music is kind of a tool that we use. So it might be creating a playlist, but also having a conversation around that playlist and how it can be used and why it's important to you. It could be a lyric analysis, talking about the lyrics and why it's important. It can be songwriting. It can look like so many different things, but we use a music intervention to reach a non-musical goal, typically non-musical goal. And like I said, not just for children, it's for across the lifespan. At Beyond Play, I do provide music therapy services there as well for all ages. And we also provide play therapy. So with play therapy, I mostly work with children with play therapy, but we know that can be beneficial for all ages as well. So with children, we know that with children, play is the work of children. So you might see a child reenacting something that they just seen or experienced. An example might be they've seen an ambulance go by. So you see them playing repetitively with an ambulance and recreating that scene. And that's them doing the work. That's them processing and learning and growing. And so with play therapy, we provide we have several playrooms that have toys, which is the tools that kids use to work through what they need to work through. And we, the counselors, are more of like the therapeutic guide rails as they work through what they need to work through. So that can be providing language for them, increasing emotional vocabulary and intelligence, and really work to building self-esteem and confidence, and we do that through those therapeutic guide rails, the techniques that we use in the play therapy session. So children, and I work with parents as well and talk to them about, is it concerning that they're playing this scene over and over again, and working with them and letting them know that, that's them processing it. And that's done through play, and we know that's the work of a child. And so the therapeutic guide rails can look like reflecting feeling. It validates that feeling for them. It gives them a word for what they're experiencing. So encouragement, it helps build self-esteem. regardless of the outcome. If they're working to build something and it doesn't work out, it didn't work out how you wanted to, but you worked really hard. And so that constant encouragement and reflection of feeling, all of these techniques that we use as a therapeutic guide rail help build that internal control for them and build self-esteem. It can decrease anxiety and depression. But we're using toys that are selected, not collected. So all the toys that we have in the playroom are purposeful. They are toys that can be nurturing. It can be, building mastery. So it can be art and games, building blocks, all of those things. But everything that we have in our playrooms is purposeful. It's selected, not collected. I think that's everything.
Could you say a little bit about sand tray therapy?
About what?
Sand tray therapy?
Yes, and we also have, in every playroom, we have a sand tray. Sand tray therapy, and we have many miniatures on the wall. All the miniatures are also purposeful, and some children and adults enjoy the tactile experience, so it can be used for different purposes. Sometimes it is kind of just playing with the sand. Sometimes it's building a scene in the sand, using the miniatures to create. That is also another way to kind of process what's happening. So a child who maybe experienced trauma can create a scene in the sand, and using symbols to work through what has happened. And so it's less direct and more in their own time, in their own space. But yes, we use sand tray, and that also, like I said, the miniatures are also representative of different needs that the person might have. And this is also not just for children. There are many adults that can, adolescents, adults, anyone can benefit from using sand tray. And the first sand tray training, those of us that are certified in sand tray, the very first one is us. The level 1 of sand tray is us using sand tray ourselves to know what it's like to experience building a sand tray. But it can really bring up a lot of things that sometimes you don't even expect. But it helps us process without saying it. So it kind of gives us a way to work it through without being so direct.
Okay, thank you so much.
Thank you.
And now we're going to move on to the other side of the panel. So, Connie, could you please go?
Good morning. My name is Connie DeWall. I'm the program manager for Will County Substance Use Initiatives, which is located out of the Will County Health Department. I'm also a certified recovery support specialist, so I'm a person with lived experience who works with someone with substance use, try to get their life back on track. They have their therapy portion. I help them get their life back, whether that be finding their doctor, getting their ID, anything that life has taken away from them, we're there to guide them back into that, into their life. We also do the Narcan training, which I have my team members here, Patty and Mark. Naloxone training and education. Everyone knows what Narcan is. It's the opioid reversal drug that helps someone recover out of an opioid overdose. We also, at the health department, we have IOP for substance use, outpatient, we have adult mental health programs, and we have child and adolescent programs at the health department. I'm so nervous, I totally forgot. But I wanted to touch base on really the Certified Recovery Support Specialist part of our program at the health department. We just started that program last year. We also have services at the Will County Health Center, which does offer MAT, which is the medically assisted treatment. They do Vivitrol and they do Suboxone or buprenorphine there as well. And we also have a peer support there. And we've found that our patients are making it to their appointments, because that was the biggest thing, is not making it to their appointment, not having that follow through. And sometimes when someone who has lost everything, and I think it was touched on, their family's not talking to them, totally disconnected from life, we offer that wellness. It's an 8-dimension wellness plan that puts them on a track of their emotional, their physical, their financial, environmental, trying to find work. All of those missing components that can keep someone from actually making it to their therapy appointment. Helping them with transportation, that's always a barrier. It's a certified recovery support specialist helps someone break down the barrier so that they can get to their treatment that they need. It also takes a lot of assistance off of the therapist who a person is so consumed with trying to get their ID that they can't focus on their therapy. So it kind of takes that case management off of the therapist so that they can get in there and get what they need and know that they have another support system with them to help them get everything else. Because when you have substance use disorder, and I know I'm a person with lived experience, I've been in recovery since 2007, and losing everything and trying to gain all that back really is a life journey. It doesn't go away. I always say I wake up every day with untreated alcoholism. If I'm not getting my medicine, which is my own recovery path, is I'm abstinent, so I choose a program that helps me with that. I'm not going to make it, during that day. I may not have a drink of alcohol, but you might not like me because my attitude might not be the greatest. So I have to work on all that, and with assistance by someone who understands what that is like, you totally have low self-esteem. Well, for me, the only way I could gain self-esteem is to be doing esteemable things. So trying to help someone, being of service, has really gained the recovery that I needed in my own life, and then having a job that supports that. So to guide someone into life, I was watching the other night that because of the fentanyl crisis and everything going on with that, someone can be in recovery, but there's only a 10% chance of someone staying in long-term recovery. So any piece that we can give another person, another human, to get their life back, breaking the stigma is huge. The opposite of addiction's connection, staying connected. All of these little pieces that we have in life are temporary. What does a person do with that after maybe their therapy is done? They've gotten to the point in that maybe they've decided that they're ending their medically assisted treatment because they want to go a different route. We're there to make sure they stay connected, and that's the biggest thing, is that connection for the rest of your life. I can't do this by myself. I'm always going to need something or some person in my life to assist me. So that's what I love about my job, and what we've done as far as in the health department, in the county, in Will County, as far as bringing our overdose deaths down with Narcan. We were at an all-time low last year, but however, it's not going away. So treatment options and treatment is still the biggest thing out there that we're making sure that folks are able to attain, because addiction's not going anywhere. There's always something coming behind it. There's nitazines out there. There's now the big talk now is kratom, and marijuana is legal, and all these different things that alcohol is still legal. So all these things that a person with substance use disorder faces, we're there to make sure that they can still get through all that. So that's what I have.
Awesome. Thank you so much. That was great. Patty?
Hi, I'm Patty Johnstone, and I am the director of the Living Room program here, not here, but in Orland Park. So the Living Room, if you're not familiar, it is a free service that is offered to people who are experiencing an increase in their mental health symptoms, but don't need the level of care of the emergency room to address those symptoms. So we are open, first of all, 24/7. You can access us in person or remotely by phone. So what happens when a guest comes in, we call them guests, not clients and such. So when a guest comes in, they are first greeted by a recovery support specialist, that peer support piece that Connie had mentioned. And they're kind of introduced if they've never really been to a living room before, what the living room is about. And then they meet with one of our clinical staff, who does a general screenings to make sure that we're at the right level of care for that person coming in, for that guest coming in. And then the majority of the time they are spending with that person with that lived recovery experience. As per Connie's point, that, speaking to others, who have gone through their own recovery journey, for us it's mostly primarily mental health, but it could be co-occurring substance and other things that are going on with that guest that comes in. They may hear it differently, and I can relate to that in a little bit here, for I could just say I am a family member of. We also support the families So for me, I would have been delivering messages that, my son and family members were not open to hearing, but if someone else is delivering that message because they've lived through it, they're more likely to want to be able to take that message and say, okay, well, maybe I will consider that. So besides the living room, we have several different things that we offer as well. We have many groups. All of our groups are hybrid. On the table in the back over there, unfortunately, it's the unlabeled tablecloth in the back over there, but it speaks to the many groups that we have. So we have a substance and mental health support group. We have Recovery with Pride. We have coping skills. We have many, many different things that we would be able to offer. And by offering that hybrid option, we know that sometimes transportation, mobility, many other factors can make it difficult to come out to Orland Park, so that we try to make it as easy as possible. The other couple of programs that we have our peer recovery counseling program. So if a guest comes in and, utilizes the living room, they're going to get whoever's on staff at that moment. But with the peer recovery counseling program, they may connect with that recovery support specialist because maybe they themselves have mental health and substance, and speaking to someone else on a regular basis to have some additional support would be helpful. So then we can match them to that person, work on weekly recovery goals. As long as they're not therapy goals, we're not trying to take the place of therapy. And that way, again, it really helps support the person. We also, kind of parallel to that, we have our version of peer case management. So we do help people sign up for benefits. We have people who are assisting, like in jobs and other things that the person identifies would be the most helpful for them in that recovery process. And like I said earlier in the beginning, we support the families as well. We have a lot of family members that navigating the mental health system can be very challenging, as well as, when do I call 911 or 988, or, how do I get my loved one help in all those. So it helps to have someone walk alongside them to be able to support that when they're not sure what to do. So really quickly, I know that we are kind of running out of time constraints here, but I would just say that, like on the family side, that's been my experiences. I had lost a spouse to suicide, and I have a son who has mental health concerns and condition diagnosis, but he has some cognitive challenges because he also had a brain injury. So we have many people come to us with many different mental health symptoms and maybe combinations of things. There could be mental health and intellectual disabilities, mental health and autism, mental health and many particular different types of diagnosis, whether it's experiencing paranoia, delusion, mania symptoms, depression, anxiety, all those things. So again, we're free and we're 24/7, and under the right circumstances, and meaning that that's a decision that's made by the team. People can stay with us 4 nights to 5 days. It has to be because there's a mental health concern that would need that, versus, they can have secondarily be unhoused, but the primary concern needs to be mental health. So that's a little bit about what we have to offer at the living room.
Thank you so much, Patty. And one thing I'd just like to reiterate is you had talked about 911 and 988. 988 is the crisis number for mental health. On the Homer website, we will have, I think we already have information, but we're going to have more information on how to use it, and just for the community to know that that is a number to call. Thank you. Go ahead, Dr. Duluth.
Good morning. My name's Tony Delich. I'm a retired pediatrician. So I was in charge of taking care of babies to adolescents and kind of seeing them pass into adulthood. But what I would like to do today is just talk about some observations that I have in treating behavioral disorders in children, adolescents, and adults. I kind of specialize with ADHD, which is attention deficit hyperactivity disorder, mood disorders, and I had a large autistic group of kids that I treated. So the observations are that, first of all, mental health problems start very early in life. Only about 20% of children receive adequate care, maybe a half receive some care. So we have a mental health crisis here in the United States, and we have to go ahead and continue to ask for the funding, get our legislatures to go ahead and put in some sort of financial taxes or whatever we have to go ahead and try to make the system work. What I feel is health concerns are not able to be diagnosed by doing blood tests or x-ray tests. We do have, down the line, we have some genetic testing that's promising. But it comes to the counselors that go ahead and does their due diligence in getting the signs and symptoms of what the disorder is, and then going ahead and developing a treatment plan. And it's just wonderful listening to the people talk up here. I'm asked, why are certain disorders now more diagnosed, like attention deficit disorder? It does affect 10% of people in the United States. It goes on to adulthood. It's hereditary. So I started seeing adults in my pediatric practice because they would raise their hand and say, well, Dr. Tony, this is me. You know, what are you going to do for me? Adult psychiatrists thought that ADHD was a child disease and not an adult disease at all. So I started treating them because I think by treating the whole family as a whole, it's important. When you talk about mood disorders, number one cause now of death in teenagers is suicide. It oversees trauma and cancer. We have to do a better job in identifying these disorders. And it affects us all. I like to tell you a brief story. I have 16 grandkids. We were with 10 of them at Christmas Eve dinner, and we said a prayer, and then the kids would go around and say what they're thankful for. So they talked about, you know, food, God, toys. But the one that really hit me, he's 13 years old. He has ADHD and a mood disorder. He says, I'm thankful for having somebody to talk to when I'm being sad. And kind of hit me in my heart. And 3 weeks later, my daughter, who's a physician, called me and says he was cutting his arms, and there are also ligatures around his neck. She asked him, why were you doing this? She says, well, this girlfriend of mine, now they're in 8th grade, and girlfriend of mine told me that if you love me, you will cut yourself. So we have problems with cell phones, right? We have problems with the internet. And the COVID didn't help us at all, too, with isolation of these kids. But having depression and anxiety, it's kind of like a teapot on a stove. The steam comes out, you got anxiety, and if you don't get the teapot off the stove, boom, it explodes. There are chemical reasons in our brain for ADHD. There's norepinephrine and dopamine. These medications help greatly. It's like putting on glasses so you can see, but the treatment is, I always say it's kind of like the 4 posts on a table. Medications is 25%. It's working with the school, educating yourself. I have some wonderful handouts about IEPs and 504 plans. The parent has to be the advocate of the child. There's no doubt about that. And getting what they need to learn, you have to speak up, and getting the right diagnosis and medication. And certainly if they need counseling is so important. Lastly, I want to just talk briefly about autism. It's been in the news. The president said it used to be 1 in 3,000 kids were diagnosed. Now it's 1 in 100. And what he said is true. So that's 1.5% of the population. It has nothing to do with vaccines. Nothing to do with vaccines. There's associations with autistic, increases the autistic outcome, such as if a mother smokes, does drugs, drink. There was a recent study that I saw that 3.5% increase if you take Tylenol during your pregnancy. So we have associations, and we do have some genetic markers, but it staggers me that why all of a sudden we're able to diagnose more of these kids. Part of it is due that we're just better at diagnosing. Pediatricians, when you come in with your child at 2, 4, 6 months, 9 months, a year, there's developmental screens. When they fall off the curve, then you have to go ahead and find out why that is, just like if the head circumference was too big or too small. And early intervention is important. There are medications that are used for kids with autism, but all these, I'd say fake news, I'm going to use the president's saying, but there's a lot of things that are coming up, especially with the new regime. They're looking at regulating psychotropic medications for kids, and I think that's going to be a mistake. If you take this tool out of our hands, then just as we heard when it comes to substance abuse and so forth, it's not a fix for that. It's slowing down the mind so you can think, so you make better choices. And this is the importance. And lastly, I want to just talk about guns. 1 in 3 guns are not locked. 69% of suicide by firearm is from the same house. So please, one thing is, I'm not going to get into your amendments or whatever, but having a gun unlocked, or a gun in the house, you have to be vigilant, especially with adolescents. And I just told you about my grandson. So it's important that we look at mental health not as a lazy, dumb, stupid, crazy disorder, but a disorder that transcends genders, transcends cultures, transcends your religion. And it's so important that we don't make this a taboo thing. And the importance is that you get the right diagnosis. So if your family practice doctor gives you 10 minutes and says, oh, you're depressed, oh, here's some Prozac, call me in a month. That's not the way to do this. We do have scales that are used that maybe you've seen these, but that your primary care doctor wants you to fill out. At least this points and the screen helps to do a more proper referral. So that's it. I almost got the electric shock collar because Dr. Snow said, if you talk too long, I'm going to buzz you. And I said,
Thank you so much, Tony. We really appreciate it. And I wanted just to, when you were talking about some of the assessments for anxiety and depression, that is something we plan on having on our next panel discussion in September, is also some free mental health assessments. We'll also maybe looking at having some information about that and maybe having some time of that during the Homer Days too, so that we can have the public come and just get assessed to find out if there is an issue or not, and then what are some of the resources that are available to help with that. So thank you so much. I'm glad I didn't have to use the shock collar.
I felt it buzzing.
Go ahead, Mark.
Yeah, hi, I'm Mark Raber. I am simply a neighborhood Homer citizen here, and I'm on the Homer committee that was started by my friend Joe Baber a few years ago. Pretty grateful for that. He assembled a bunch of doctors, Dr. Snow, Dr. Tony, some law enforcement, and some people to just kind of spitball some ideas on how to get education and resources to our hometown. And I think it was pretty successful so far. An amazing group here. So much information from all these, professionals and doctors. A lot of words, a lot of information, and I think that's what we're trying to do. It's almost overwhelming how much information these people have already provided, and it's the right thing to do, because I can tell you as a parent, just a regular person in the town here, when that kind of stuff happens to your family, you're looking for everything and anything to get support and resources. And over the, X amount of years that I've been exposed to this, it's amazing how much support has been developed all the way down the line. And just some key words and everything they said, it's almost overwhelming to try to understand it all, but that's kind of why I'm still staying around, is just for the education part, to reduce the stigma, the awareness, and just be part of this panel to hopefully have resources for when this does happen in your family, because it does happen to everyone. It's not, isolated. It can happen to anybody, and I'm talking about addiction, which is why I'm here. This happened to our family. I'm also a big supporter of Al-Anon, which is definitely for the parents and a brother, a sibling, anyone who's connected, who has a loved one who's suffering from the disease of addiction. And it's Al-Anon is a program that's in every city and every town. There's several meetings a day. They touch on a lot of the stuff that this group has already talked about, and it's free, which I think is amazing how many resources are out here that are free. So again, that's one of the reasons we're all here, to get help to people. So Al-Anon, it's in Homer, it's in Palos, it's in Tinley. There's a meeting every night of the week, and what you could find there and what I see there is a lot of people come in pretty broken with no idea on what to do, how to help themselves, how to get stronger, just so they can then in turn help their loved one who is suffering from the disease. And it does work. It's amazing, and it kind of works hand in hand with the counselors. So I'm a big proponent of that. You could probably go on our website and find more information about Al-Anon, or just Google it. I'm also a big supporter, our family is a big supporter of the Center in Palos, which is an outfit that does help like about 15 men that are in recovery in Palos, and they live there for a year for free. No insurance, and it's, I think Connie talked about it, and you talked about aftercare. When they come out of programs, they need more help. They can't just be dumped into society and say, oh, here you are, you're better. And believe it, these kids are people, they want to be normal, they want to be just like us very soon. And so there's so many battles and hills they have to climb. So the center does a great job. The people, men, work the farm, they work the kitchen for 1 year, and then they go out to other resources like this to help continue their life and build their life back, because they've dug some pretty big holes. But it does work. It's a great place. It's at the Children's Farm on Southwest Highway. And we have a special interest there, because our son, the reason I'm here is our son suffered from addiction and did lose his battle to fentanyl about 8 years ago. And he did go through the program there. And again, want to be normal, want to be better. You make a mistake, and someone touched on fentanyl and Narcan and how dangerous all that kind of stuff is, and it's all true. And there needs to be more education about it, from the family level to the people who are suffering from addiction, and just realize it's Russian roulette. It's just too prevalent. It's in my neighborhood. It's on your street. It's everywhere. And that's the other thing, is awareness, education, and fear, because you shouldn't be embarrassed about it, but we are. But this crew here, boy, everybody said some great things. I'm glad you guys are all out there to support these people who are suffering from this disease. I think our Homer panel that meets once a month, and Dr. Snow and Dr. Tony have come up with some really great ideas and assembled this panel in addition, and it's just great resources for people just regular people to reach out, because, man, it's a pretty scary place when that does happen to your family or your loved one. And I appreciate your guys' effort. That's all I got.
Thank you so much, Mark. What we'd like to do now is open this up to the public to see if there are any questions, and you can deliver that to us in general or specifically to somebody, depending on anything that you've heard. And, okay, go ahead, please.
Well, I have so many questions. I don't even know where to begin. There's such a vast amount of knowledge up here that's so much been shared. Thank you all for being here. And Joe, I didn't realize you started this committee. And a few other people. Good for you. I like you. I think this is an incredibly valuable discussion to be having. And it's one that I know I didn't grow up having. And I think we're also And so it's fascinating. My question, I guess, would be for Dr. Tony, in terms of the uncomfortableness about having this conversation and why it's so important. How do we encourage this conversation and get more people comfortable having this conversation? Because I think it affects all of us. Whether we have someone with a diagnosis of ADHD or autism or bipolar or anything, it impacts us one way or another. And I think you're right. The pandemic was an accelerant for a lot of mental health issues. And the internet and raising children, it's a scary time to be raising kids. There's this huge show on Netflix, I haven't seen it yet, called Adolescence, but I hear it's pretty scary in terms of the mental health issues that can occur through internet exposure. So how do we normalize this conversation, I guess?
Yeah, there's a bibliography that I have with self-help books and so forth that's geared towards the patient as well as the parents. But I think having a conversation is important. As a pediatrician, I always told parents, you look at bozo buckets. Everybody knows here what bozo buckets are. So you got 1 and 2, these are smalls, right? And kids, they play mind chess with you all the time. They try to see what your weakness is, and if mom doesn't give in, then they go to dad or somebody like that. So I try to tell them if your child is having issues where the defiance just doesn't come up with FU once in a while, but these are biggies that have to be addressed. I think when you talk about mental health care, this is where you say, well, I don't have a problem, you have a problem. You know, Mom, you're smoking weed, I don't say anything about that. So what the counselors do, and it's important, is they go ahead and go through issues that brought them there. And I always say it's not a disorder of intelligence, because usually these kids are very intelligent, but it's a disorder of performance. And for some reason, if their performance starts falling off, say, hey, you went from A's and B's in school to D's. And the parent would say, you're not trying hard enough. Well, I don't know. It's like I would offer a mother $10 to say, your child has 104 fever, here's $10, why don't you bring it down? You have to go ahead and show them why there's an issue and how we're going to go ahead and progress. I don't know, Dr. Snow, do you have anything?
Yeah, I think, there's a couple of things to this question. I think one of the things you were asking was about, the stigma and how do we start those conversations? And, I think a part of it is recognizing that it is more widespread than we said, and it's getting out there and talking about it because it affects all of us, just like we've seen here. I'm a single mom living in the community who's raised 6 kids here. I had a son who also struggled with addiction, and thankfully we made our way through it. But I can tell you, as a counselor and a mother, I helped so many other people with addiction, but when it came to my own son, I'm his mom. I'm not his counselor. And so, just getting the resources out there for him. And thankfully now, he has a 3-month-old little girl, and for me to see him with her, it's just, I never knew if he was gonna be alive, never mind married or a father. So, I appreciate all of my grandchildren, but seeing him with her is just, it touches my heart because, I didn't know. And, I know with my children growing up in this community, one of the challenges, I faced as a parent was there wasn't a lot for kids to do. We've got some great sports programs and everything, but it's like, what do they do afterwards? Where do they hang out? At that time there was the Orland Mall, but there wasn't really a lot of other things, but it's like, what positive activities can we have for teens to do? And for parents out there is be a space for your friends, your kids' friends to come over. And I know for myself as a parent, one of my best ways to know what was going on with my kids was when I was driving them, even if it was 1 o'clock in the morning to get White Castle, I am shutting up and I'm listening after that school dance because they're talking. And I'm taking in that information. And I'm finding out more from driving them and their friends when no other parent wants to drive at that time of night. but I'm finding out more from what's going on with them than sometimes they're telling me. And, you know, like was said, you know, before with the show Adolescence and just the time that's going on, parenting is different than it was for us. I mean, with the internet and phones, there's a whole world that parents don't know about. And so we want to try to educate ourselves as much as we can. That does mean also, you know, sometimes, you know, getting involved with like police departments and having police department. We had a police department come out to my practice after we had some kids who were talking to men in other states who were pretending to be children. And it was affecting our clients. And so I'm like, we need to be educated on this so that we can then better advocate for our clients and our parents. And, but it was also, we're parents too. And so having the police department come out and do a presentation for us as counselors to educate us on that. You know, Tracy's come out and talk to us on domestic violence. You know, I've had domestic violence in my past too. You know, I wish I knew some of these programs were around, you know, at the time I was going through it. And so I think it's recognizing that it affects all of us. And we've got to get out there and talk about it. 1 in 3 children who are in school, you know, or school age have mental health issues. That's huge. And unfortunately, school counselors can just touch upon it. I mean, there's one, I mean, ideally with ASCA, which is the American School Counseling Association, there's supposed to be 1 counselor for every 250 students. In Illinois, it's like 1 counselor for every 500 students. In California, it's 1 counselor for every 900 students. So there's no way that they can touch upon this. Often what those school counselors are doing, they're playing more of that prevention role that we heard about here, where they're identifying which kids do have issues, and then they're referring them out to the agencies. And we can tell you, you know, when we work with kids, you know, it's, you know, getting the parents on board. Sometimes it's hard to admit my kids have problems. You know, and we feel like a failure as a parent. Like, what did I do wrong that my kid is this way? Instead of recognizing that, you know, let's go to my own counseling for that, but let's get my kid the help that they need. And because a lot of times it is a family issue. It's not just, you know, a kid issue. And that's one of the issues that we have as counselors too, is we can build up that self-esteem for 1 hour a week, but then if we're sending them back into a toxic environment where everybody's struggling, we can only do so much. And so it's us all coming together as a community to help.
I'd just like to touch on that a little bit more too about internet and games. And as a mom myself, I fight that struggle every day. And it seems that a lot of the games too are even created to be like, I just need more time, and they continue and continue and continue, and there's no end. And so it really is this struggle that even like the games that I grew up with, you know, it would come to an end, or these just seem to be pulling the kids into for a longer period of time. So it really is a struggle. One thing that I work with parents at is therapeutic limit setting. Like, how do we set limits around these things? So working with the child with these limits to understand them, but I'm also working with parents to how do we do this in a way that, you know, we have different parenting styles. The ideal one that research supports is the, you know, authoritative, where we are firm but understanding. So it may look like, you know, you feel really frustrated that you can't continue this game, but we know we come off at 5 o'clock, and providing other options. So we teach parents the language to use and what it looks like, and how we do this in a way that is respectful to the child, but also very firm in the boundaries. So it's not like some people say gentle parenting. It is, but also very firm. You know, we know kids need these boundaries and need to know what's safe and what's not safe, and it's up to us to set those boundaries. So we teach parents how to do that in a way that's therapeutic and effective.
That sounds like a tremendous resource, and I appreciate you pointing out the fact that it's different than
Very different.
when we were younger. And Dr. Snow, I greatly appreciate you pointing out that this is a new parenting challenge that no other generation has had, because in addition to developmental mental health issues, or you know addiction issues at home, or toxic environments, now we're exposing them to this thing that has tremendous impacts on their dopamine system and everything that becomes very addictive. We have no idea how this impacts human beings developmentally. And they're on it. I mean, these kids are on these things. So it's not just the child predators, which is
Right.
also a concern as well. And we've had programs like that in our community where the police have come and talked about. That's also very scary. But I guess more day-to-day bigger concern is that how is this technology impacting them? And so I love the fact that you teach parents how to, because I think parents have no idea. Because this is something my parents didn't have to deal with. It's like, go outside and play.
And everything's being brought home with them. Also, you know, you have your troubles at school, but then with social medias and things, and I know a lot of social medias have age limits that kids learn how to get around and change your birthday. You put in any birthday, right? Yeah. And same with parental controls. I've learned that they can get around some of them. So yeah, it's being active but learning how to do it in a way that's respectful to the child and what they're experiencing, but also being firm with boundaries. So yeah.
Go ahead. Oh, go ahead, Doctor, you're more.
I think just one thing, I tell parents sometimes we forget about being complimentary. I tell some parents, you know, you keep saying the negative things, it's like a wall. I says, for one weekend, don't say anything negative. Let's just focus on the positives. And it's amazing, hey, Mom, I made the bed, how about that? You know, it was a good thing. Just a small thing. Go ahead.
So I have a 34-year-old, a 29-year-old, and a 26-year-old, but now I'm fostering. So now I have a 5-year-old and almost 3-year-old. So starting over. So, you know, I told my oldest, you don't want to grow up like me. Like, let's just cut that right now. Let's just talk about, and my kids are great. I brought them to Alateen, and I gave them the best foundation that I could because they were early teen and adolescent, and so they saw their mom at not the prettiest sight, but you know, only by the grace of God and my husband and giving them the right foundation, all 3 of them are successful in their own right. Now I'm starting over, and I have a 5-year-old and a 3-year-old, and the 5-year-old who, when I got her, she was 3, she already had screen time, so she was already on an iPad, and I don't think the kids ever went outside. And you know, I'm learning all these words of redirection and positive affirmations for trying to change their mindset or give them some sort of foundation because I don't know the outcome for them. So I've been fighting for them IEPs and 504s and getting them all their therapy, occupational therapy, developmental therapy, trying to get ahead of things because I know their mom very well and mental illness does run in their family. So trying to get ahead of the game so maybe they have some sort of foundation if or when they go home, it's a mess. But when I brought them outside, to just be outside, because, you know, I'm an 80s baby, so we played outside till the sun went down, and that's how you knew it was time to go home. And Mimi, riding their bike, and we got them, and just for that, and so that's what we do, is we're outside and limited. You know, there are some good games that they'll play on their little pad that they have, but that's like it maybe 45 minutes, if that, but outside playing blocks, reading. Our 2.5-year-old loves to have a story. Now they're not conditioned, but they have consistency. So it's almost like they don't tell time yet, but they know, oh, it's 7 o'clock, Mimi, Papa, we're gonna read a book. So trying to get them, you know, in consistent behavior. So hopefully, you know, I don't know if that's correct, but hopefully if they go home or whatever their determination of what's going on right now, it's just a mess. But I know we're going to have them for another year. So hopefully I can either not mess them up or even more, or try and give them a good foundation. But I'm hoping the latter is giving them a foundation. But you do, as a parent, waiting for like our services to get them services, I had to do it myself. And there were things I did out of pocket till I could get them services that they were, because otherwise it was a waiting game. I mean, our 3-year-old or 5-year-old just got into services, and it took a year and a half, and I was doing some stuff out of pocket to get her, because she had some trauma coming in. She was very fearful of her mom's boyfriend at the time, who's her little brother's father, and she's still in that domestic relationship because she's afraid to leave, and she doesn't know the dynamic of she's going to lose her kids if she doesn't leave, and she won't. And she had another baby. So that's, another thing is trauma is now they have a little sister now, and it's all this confusion. So advocating, I mean, I'm spinning the wheels just trying to give them something,
Well, thank you for the work that you're doing. God bless you. Anytime that, I hear of foster parents being out there and making a difference, it's a lot of hard work, and it's definitely needed. So thank you for the children. Okay.
I think Dr. Cohen made a good point about complimenting your kids, because if you fail to do so, with the peer pressure that we're seeing with them, they fall into a bad loop, let's say, of people that then are giving them information that they're part of that group. And that's where you start getting into the bullying and other problems. I think that parental interaction to support the kids is very important way to fall into the
Go ahead.
Speaking of the mental illness portion of this, some diseases present at different ages. Could you elaborate on going through the years of a person's life from birth to, say, 30, because like schizophrenia can present later in life? What are some of the mental illnesses or things that are presented or diagnosed at certain ages in a child's life? What should a parent account for as they raise a child?
We're all looking at Dr. Tony.
Yeah.
I have this here, I'm trying to find out where I put it.
I'll talk while you're finding it, and then you can jump in. So thank you for that question. There are a lot of disorders that we do see developmentally. So typically around the age, developmentally, if a baby's not making the milestones, and that's what parents, especially if you're a new parent yourself, you don't necessarily know what those are, talk to other parents. But typically there's a gauge. So you don't want to sit there, like walking is the average of about a year, but it could be 9 months, it could be 18 months. Talking is typically around that same time. So developmentally, you start seeing some things. Behaviorally, you start seeing it with like preschool, when they're in the school and they're acting out as compared to other children, is sometimes that it might be highlighted, especially if it's a family that's very chaotic, because that child's behavior is quote unquote normal with everybody else in the family, but then when they're in another setting, they're finding that they can't control it and they can't emotionally regulate it and everything. So with ADHD, a lot of times that, and also, when we're looking at the neurodivergence with autism and Asperger's, it's always ideal if that can be diagnosed earlier, because then we can put interventions in place. I know my grandson has autism, and thankfully his parents caught it early, around 2 or 3. At that time, he could communicate, but not that well, but he was using violence as a way of communicating, and every toy was a weapon. And so they had to give his older brother self-defense lessons to protect him against his younger brother, because he didn't know how to communicate. Once he learned how to communicate, we really saw the behavior, the violent behavior drastically reduce. And thankfully, he's doing fantastic now, but it's because my son and his wife were very actively involved in making sure that they had the care for their son. What we also find is some things can also be triggered by life stressors. So for example, if there's a divorce going on in a family, or if there's a loss or grief, children are going to act out as a way of, because they can't process what's happening. So again, we want to look for those behavioral changes as parents as a way to maybe assess if something else is going on. Other mental disorders, like I think you talked about schizophrenia, those we're gonna see in later adolescence, early 20s, where that starts presenting. So again, it depends on what the mental health issues are, the behavioral health issues are, and when they present. But, I would, I'll definitely defer to Dr. DeLocke, but, I'd say if your child starts acting differently, pay attention. Pay attention, talk to your child, and maybe, talk to a professional and just get some ideas, because it's always easier to treat it earlier than later.
Really quick, when it comes to substance use, I had a 14-year-old client who showed up to school and was sent to the hospital, and she did a breathalyzer of a 0.22. When her father asked her, what happened? Why did you do this? Her father, in my case, understanding, is a functional alcoholic, and she looked at her dad and said, I wanted to know what you felt like. Substance use, kids are getting vapes, they're getting alcohol at such an early age. It is really, really alarming. And then if untreated, they will then come into my clinic at the age of 18 with a full-blown fentanyl addiction.
Thank you.
So I wanted to be sure about the age of onset. So autism is 0 to 3 years, and the complications, risk of aggression and self-awareness. ADHD is 3 to 7 years, failure, identity, and conduct problems. Anxiety disorders is 6 to 12 years, and that is complicated by avoidance, and coping and accommodation leads to failure and transition. OCD, or obsessive compulsive disorder, 6 to 12 years. Tics, 6 to 12 years. Eating disorders are in early teens. Depression, mid-teens. Substance use, which causes progressive with some spontaneous recovery. Psychotic depression, mid-teens. Mania is a late teen onset, and this is burnt bridges, a worsening of symptoms. Schizophrenia in young adults, young adult onset. So it's important, once again, that we recognize these issues start very early. And as a pediatrician, I was always looking to prevent something from happening, to prevent it at a stage of self-medication. But we had 3,500 overdose deaths in Illinois last year. 3,500. That's incredible numbers. And it's so lethal, these drugs, and it's available, whether you're in Homer, Glen, Orland Park, it doesn't make a difference. I think if you're a parent, and it's tough, of course, when my kids wanted to call DCFS on me because I chased her with a stick once. So, we lose our cool. Things happen in our lives every day. So it's trying to be a joint venture, but, it's no matter what you do, and things happen, such as I told you with my grandchild, it's not your fault. And this is an important thing. Rick Harris, he's on that Pawn Stars show. His son was 32, he overdosed. So they asked him, I think of this every day. But he says, I also keep thinking, woulda, coulda, shoulda. Now, he had a lot of money. He had 5 treatment programs and so forth, and he overdosed on fentanyl. But the fact is that sometimes it's a train. Can we steer it towards the right way? But sometimes we can't. And I feel for the parents in my practice that had to go down that road. And I said, in this case, Rick Harrison said, see, I have 2 other kids. I have 4 grandkids. I look forward to these things. But it continues to be a stigma, and it's something that we have to attack early. And as I said, these disorders start very early in life. And if you're a parent, if you think something's wrong, there's probably something wrong. But get the help you need and get the correct counseling and diagnosis, and then coming up with a treatment program is important.
I have a question for the panel, kind of based off on that same one that you just asked, about identifying the symptoms and at what stage of life. So, I would say we had a kind of decent normal life, sports, school, high school, and about sophomore year of our son's career, he called up and he said he had a night terrors and panic attacks, and I was ignorant. I had no idea what a panic attack was. I was like, well, we don't know what to do with that. So we suggested he go down to the school infirmary and talk to the psychologist. Well, they gave him, I don't know, some anxiety drugs. And at that point, he was chasing the pill. So I'm, and this could be controversial because I'm not a big fan of, pills right away or labeling right away. But how do you, I don't know, how do, I'm not blaming them or me, but part of me says, well, man, I wish he wouldn't have been taught or shown to use this then, and then it just kind of snowballed with the oxy and, all the way down. So how do you deal with that when someone in authority diagnoses pills and they have that addictive gene?
Well, I know at our practice at Beyond Healing, we use medication as a last resort, not a first. And I think even when medication is used, it needs to be complementary with talk therapy and coping skills and everything else. So I think it's first assessing what is the level of anxiety. I have a granddaughter right now who's struggling with some anxiety, and I think they have her on something now, but there was a year first of trying other alternatives before that. And so, I think it's looking at what are the, teaching the coping skills. What's exciting with the field of mental health now that I've seen it, in the last, 5-10 years is epigenetics and neuropsychology. Before it was, if you're depressed for life. If you're anxious, you're an anxious person. You're going to be on pills the rest of your life or whatever. Now we found that we can rewire the brain and we can change the way of thinking. So the way I talk to my clients is I talk about it as, anxiety or depression are poor thinking habits, but they're habits that can be changed. And so, it's not this, determining fate that this is what you have for the rest of your life and you just have to deal with it. It's, you can change it. So it's empowering the clients and letting them know that, we can rewire the brain. Just the other day, one of the other treatments we do in our practice is EMDR. And I had a client come in and he just overloaded with anxiety in his early 30s. But, and it goes back to family of origin issues of, his dad was always really hard on him and everything, and he felt like he needed to please everybody. And he had a hockey game coming up that should have been a fun thing for him, and he's just riddled with anxiety about this game that's coming up. And so, I've worked with him for a year or two, so I know him well, but we did an EMDR session, and within 15 minutes, his anxiety was gone. Now, is every single EMDR session that effective? No, it depends on the person and what the treatment's used. But we were able to do EMDR, which can be used for trauma and any any sort of memories that are filled with emotionality, and just help to take out the emotion. And and I checked in with him later on in the evening, like, how you doing? He goes, I'm doing great. Does that mean he's never going to have anxiety again? No, but there's different methods out there. So I think it's finding what methods work for which person. Truthfully,
If this kind of service wasn't available then, or I was completely ignorant of it, or even mental health. So, that kind of, if I'd have known this then, it probably would have, had early education.
Well, and the problem with substance use is there's no guarantee. Yes, it could be genetic. It could not be genetic. So a physician is never going to know if I prescribe this medication, is this going to trigger that addicted gene? One of the things that I actually love about Symmetria is our psychiatrist will not prescribe any of our clients benzos just because we already know that our clients have that addicted part. If you know that you have that addicted part, it's within your family, it's being honest with your doctor and telling your doctor, I do not want any of this, I do not want any of this, to make sure that I don't then fall down that rabbit hole and chase the dragon every time I'm taking a medication.
Well, you've got to look at brain development, right? Your brain isn't developed till you're 25. So for me, when I was seeing, adolescents being prescribed medication and their brain isn't fully developed, also what I was seeing is marijuana usage. Well, now they're saying marijuana usage in children are causing the psychosis. So if they're not disclosing that they've been using marijuana and then they're presenting with the symptoms that could be diagnosed with bipolar or depression or anxiety, and not disclosing that they're smoking marijuana and then prescribe medication, you've just countered everything out. I'm not a doctor, so, but this is what I was seeing in my own experience, again, with my foster children. Their mom was smoking marijuana her entire pregnancy. And so we're seeing a little developmental with our little one, the developmental that's happening with him. So, you know, for me and with my own kids, I've been a fascination with the brain and the developmental of the brain, and it's putting all these things on top of something that's not developed yet has always been something that was scary for me, even with my own kids. So we always went with, let's try this, the talk therapy, the play therapy, anything to stimulate the brain the right way with all the right things that are inside our body, and then get to that adult stage where then maybe all the other, if that makes any sense. I don't know, but that's just, like I said, I'm not a doctor.
And I would just like to add too, I mean, I know that, you know, we have seen and typically we can see that the average age onset is at 17 to 22, you know, category for mental health. They look at genetic factors and other things that are going on as well. But also the little, I don't mean it to be a joke, but it's like 1 out of 4 are affected by mental health, but the other 3 just don't know it yet. You know, type of statistic. And it's also, that's our statistic. Don't quote me on that. But the other part was that, you know, mental health is really kind of known as that no casserole illness. So if you have someone in the community or friends or family that might have some sort of physical health symptoms going on, people might gather around, they might cook for them, they might help support them in many different ways. But when someone in the community is experiencing mental health concerns or conditions, people are like, well, I don't know what to say, I don't know what to do, you know, so there's no casserole being delivered if your son or daughter is in a psychiatric hospital somewhere, because, you know, again, people don't know how to address that.
I did want to just touch on the signs in children really quick again, because this is pretty important, that some of the psychiatric illnesses, they do present differently in children than they do in adults. So something to look out for in kids is behavioral outbursts, a lot of anger that often will show up as the symptoms of depression rather than like just sadness. Like we see in adults, sometimes we can really clearly tell that person's depressed, they're withdrawn, and they're very sad. Whereas with children, it might not look like that. It might look like a lot of anger and a lot of acting out. So the child is not bad. The child isn't throwing a tantrum to get what they want. There's something going on usually when that's a repetitive, consistent behavior. And also the difference in the way that young girls present with anxiety and depression versus young boys, if we're gonna go with a gender binary. You know, a young woman is much more likely to internalize mental health issues, and so it's harder to notice, whereas boys will externalize. So you will be able to see behaviors that are associated with mental health difficulty much more easily in boys typically, whereas with girls, they're going to internalize that, and they might be struggling a lot internally, but not showing outward signs as much. And so with girls, it might show up as not hanging out with friends quite as much, they're quiet, they are wanting to skip school a little more, these behaviors that might be a little more subtle and withdrawing rather than the signs where they're causing issues, right? They're acting out in a classroom, they're not listening, they are having yelling matches with a teacher or a parent. Those are a lot easier to see, right? And so while those get labeled a lot of times as like, oh, that's the bad kid, there's something else going on there. They're not just a bad kid. And I really, really liked the comment about complimenting your child. I do that a lot with parents, is when they give me a laundry list of the things that their child is doing wrong. Okay, well, what is your kid doing right? Can we talk about that? Because when a kid is consistently being told all of the things that they're doing wrong, what does that do to their self-esteem and their self-worth? Not good things. And that can contribute to the development of low self-esteem throughout the rest of the lifespan, and depression. And I do see a lot of clients younger than the teenage years struggling quite a bit with depression and anxiety. A lot of times that can start right around puberty, actually, like around 12. There can be a big spike in that. So just being aware of that, as well as one of the signs I did want to mention to look out for is in regards to self-harm, because that's something that I work a lot with, is self-harm and suicidality. And self-harm does not equal being suicidal. Someone can be engaging in self-harm without wanting to kill themselves. It is a coping skill that often keeps people alive, actually. And if we try to just take that away completely, suicidality can really rise. So using a harm reduction approach is what I do. But sorry, that was an aside. What I want parents to look out for is, in the summer, if your kid is wearing long sleeves and long pants, and they're never wearing clothing that is kind of appropriate for the level of heat outside, notice that. That could be a sign that there's some self-harm going on. It could also be a sign that they're having body image issues, and that's important to address too. So I just always want to mention that because that's a very clear sign that you can see of, oh, okay, it's not internal. And a lot of this stuff is internal, so it can be hard to catch. So just noticing that.
I kind of wanted to add a quick piece with regarding to society. Medication is the #1 answer. Growing up, I was an ADHD kid, and my mom, who may or may not be in the audience right now, hi Mom, it was suggested that I go on Ritalin. As a small child, after 2 weeks, she took me off Ritalin. Because I did not have that medication component, I had to learn how to manage my ADHD. I had to manage, public speaking, sitting through school, doing all of the stuff that a normal individual would do, but I had to figure out how to do that by myself, on my own. I had IEPs. She really advocated for me in regards to school, but I didn't have that magic pill to make me sit in class and pay attention. I had to use all of those coping skills, and I had to sit and figure out what worked best for me.
That's true. You learn to compensate. And that's why, as I followed my teenagers into adulthood, probably only about 6% went on to have to take medication. And that's because you learn to compensate. I mean, we all have a little ADHD. I'm Catholic, could be the Pope up there talking. I'm thinking about Bravo or Spirit and Bear Packer game, get me out of this church. It's all about performance, isn't it? Mm-hmm. I like to mention about diets. We as a pediatrician, I tell you when you introduce vegetables, meat, and so forth. But what we fail to do is ask what a teenager is drinking. Caffeine products. You got this energy drinks, right? And all these things. These are all stimulants, right?
Yep.
I mean, we don't talk about it. Licorice, stimulant, believe it or not. So, and the other thing is about sleep. I think you touched on it, that I've always asked about sleep. And teenagers need at least 10 hours of sleep. Adults think you need 6 or 8, but good sleep hygiene. no cell phones in the bedroom, no computers because of the blue light, you know, trying to go through a ritual about shutting down. I never use Valium or diazepams because there is a syndrome now that is a cause of addiction with that. There's no doubt about it. So I would do melatonin, which I think is a pretty benign medication. But, you know, good sleep hygiene is important, good diet's important, and exercise is important too. There's no doubt about that, you know. And I always say that medication's a small part of the treatments, 25% if, like I said, with ADHD people, but they have side effects too. But on the other hand, you have to weigh things, right? I mean, if I checked your urine and it was full of sugar, I would say, well, it looks like you have diabetes if I have to go ahead and prescribe medication, but you also have to change your diet, foot care, you know, wound care, and all these other things that are involved, you know. But thanks for your observation, and congratulations. It took a lot of willpower and power, though, to do what you did, didn't it? It was exhausting for you at the end of the day.
Yes. And as an adult during grad school, I knew that I would need that extra, so I chose to talk to my doctor and go on like a short-term anxiety medication. But I've been off of it now for a couple of years.
I'd just like to add to that with some of the work that we're doing at Beyond Play too, that a lot of times we have parents come in and like, give us stuff, give us tools, coping tools, coping tools, coping tools. And I think that coping tools and medication, all those things are necessary and important. But I think the work that we're doing at Beyond Play also is deeper than that. It's, you know, that internal sense of control, that all that stuff is external, right? We want stuff to make us feel better. But what we're doing at Beyond Play is building that sense of control that I am enough. I can do this, I can get through it. We're not going to fix everything and take everything away and make, you know, everything just perfect. But how do we get through it and feel that we have the confidence to get through this and what it takes? So it's more about that internal work that we are really doing. And it takes time. So like I said, coping tools are great. I think that's a piece. Medication can be a piece. But that deeper work is also so important that I can do this myself. I got this. And yeah, so I just want to add that.
There were some questions in the audience. Yeah, go ahead.
Thank you. My name is Tim Davis. I'm actually fairly new to the community, and in a happy coincidence, I stumbled onto Gia last week, and she invited me to this. This is an extraordinary conversation that we're having, and I really appreciate all of you.
Thank you.
I've lived in a number of communities and not had this, but I actually do have a question, but wanted to kind of set it up first. So I'm the Chief Operating Officer of 2 psychiatric hospitals for youth in the city. And live out here, which is kind of curious as to what are we doing out here. And so how do we access, in those very rare instances, and we are 2 hospitals that believe that we should be the last resort. All of these things that you guys are doing are always the first line. But we do run into the individuals that do need that level of care. How do we, in the rural communities, access that level of care quickly and efficiently so that we don't have individuals languishing in the emergency rooms or maybe even in your offices while we're trying to figure out what that next step is?
Well, I know at Beyond Healing, we try to work collaboratively with different agencies and programs around.
Like SAS agencies.
Yeah, and just so that we know what's available, and also, you know, educating parents too on, you know, knowing call your insurance company, because not everything's going to be covered, and so that we're not wasting their time, especially this critical need, in going down wrong directions. Can it be improved? Absolutely, but I know that we're always looking to increase our networking. And find, you know, other resources. I'd like to open up if anybody else would like to share.
So with substance use, so that's the biggest thing, is automatic to the emergency room for detox. We've lost a lot of our detox centers who used to detox in the past and now they don't. So that's the first line, is always going to the emergency room. So that's what's been happening. Now we're trying to educate our emergency room doctors of what to do with that patient. So I know Family Guidance Center has peer support in the emergency room. We're trying to educate emergency rooms possibly to bring in medically assisted treatment to try and start someone on MAT and get them on their way. But that's been the biggest. I worked at Stepping Stones Treatment Center for 10 years. That was our biggest thing, because when When heroin started coming in 2010, we were able just to admit someone on a Friday. They would go through their detox. You're not going to die outright from an opioid detox, but you will from alcohol and benzo. So we know those different ways of detox. But then all of a sudden they're saying, no, we need to start getting them detox before they can come into treatment. So having our treatment providers be able to offer detox, Gateway does, Rosecrance does, but still our local in Will County still has to farm out to detox before they can come to treatment. COVID killed us with that too. Brandon House and Mantino used to be able to detox and transition in. So I think for me, for what I've seen is that lack of a detox, and even and I think substance use and mental health and unfunded, a person who doesn't have insurance, they have nowhere to go. So again, that component with a peer support in those settings to navigate someone to get on, because you can get on those right in the emergency, you can get on or reinstate your benefits in the emergency room. So we see that a lot. And instead of just, here's someone with substance use in the emergency room, here's a packet, be on your way, because they'll be back in 24 hours. So I don't know if that answers it, but we're trying to get those legislation and things back in so we have proper detox, but that's the biggest barrier.
And I would like to add on the mental health side, in terms of the hospitalizations and people going to the emergency room, we've been reaching out to the local hospitals, trying to be able to form those relationships as well. And hospitals in general, not looking, sometimes when there is a recovery-driven program and clinically supported, there can be a hesitation. It's like, well, okay, well, wait a minute, we're not sure what these programs are offering. I know that peer support on the substance side has been a little bit more more accepted. It's really also peer support. We also have been trying to offer on the mental health side, or those individuals who have both mental health and substance to be available, because we have tried to provide programs like a living room that doesn't necessarily always resonate with people. So if you have a hospital, for instance, and they're going to refer to a living room, and if they can't explain what a living room is and what it does, plus all the other programs that come with the living room, then they're least likely to refer people to that. But we all know that people are presenting to the living room with a lot of mental health concerns, are not needing to be at that level of care. They could be at our level of care, but it's also then having confidence in developing those community partnerships to be able to say, it's like, okay, we know that like a living room does have the clinical support, that if somebody needs to be at a higher level of care, we can make that happen. We can work with the person to be able to get them to the hospital. We can work with the family. We can work with, again, providing those things when there's not funding, and signing them for Medicaid benefits, signing them up for, other things that they might be looking for. So it's really trying to be able to look at, again, how can we have these conversations with the different providers. I mean, we've been also trying to reach out to the MCOs, the Medicaid providers, because again, we know that there are a lot of people who are utilizing other things that we're a free program, so we're definitely cost savings both to the hospital and to the Medicaid providers to be able to have these options, but they have to understand the options to be able to utilize them and recommend and refer them.
I would agree with that. Very often what we're finding is that, and I hear this story over and over from parents, they're frustrated because they sit in an emergency room for 3, 4, sometimes God forbid 5 days, and everybody just gives up and sends the kid home untreated with no resources for any of the levels of care we're talking about here. And so they start the cycle all over again. So again, very important and exciting conversation that we're having here today.
So I would add to that, Tim, as a parent, when you're headed to the emergency room as a last resort several times, dozens of times, at that point, what we knew as parents is if they weren't diagnosed as suicidal or said they were going to harm themselves, they wouldn't keep them. So you go there as a last resort and all that stuff's going on. And you're bleeding and you want to get to the emergency room, any local one, and that's what we knew would have to happen so they could go into that detox at that place and then to a 28-day program. Last resort. I think our hope with the Homer panel is, like Gia got to you, is how do we get this unbelievable wealth of information to more people in the community, like yourself. So we're hoping our website and people watch this, and then they can reach out to all these resources prior to that. And I don't know how to accelerate that, but I think, we're on the way, But how do we get to more people in town, locally, to use these sources, because these are available. They're amazing resources.
And we'd love you to be on the panel next time, too. But thank you, and I agree, it's an excellent question, because there is such a gap of services, and it's heartbreaking to see somebody who is uninsured and, it's spiraling. And basically, you're just waiting for them to crash and burn bad enough for somebody to give them the care that they need. And it's hard. It's really hard to watch, especially with loved ones. So, yeah, I know we have about 15 minutes left, so I just wanted to check with the audience and see if there's any other questions. Okay. Yeah.
Can you have somebody show how to use the Narcan for other people who are neurologists?
Mark, come on up. Patty, come on up.
That's a great question. Thank
Yeah,
you so much.
you. Do we have time for that? They can do that over quick.
Yeah.
They can do a quick training.
Yeah.
Patty and Mark, they're my lead team, and they do this every day, and they do it better than I do.
Can I do a quick spiel about Narcan?
Yeah.
So I work at Symetria. We had a client who, when he was meeting with our nursing staff, our nurse literally said, the next time you use, if you feel off, if you feel different, go ahead and Narcan yourself. He normally snorts, he ended up injecting it, and he said that he felt really weird. And he pulled out the box of Narcan and remembered what our nurse said and sat there and read it. Narcaned himself once, Narcaned himself a second time, and told his wife to call 911. He just overdosed and had a Narcan himself. He is, next weekend, will be 2 months alive and sober. Narcan does save lives.
That threw me, but that's okay. I've never heard that before. That's okay. We hear about Narcan or naloxone, which is an opioid antagonist. It is a form of harm reduction, and in Will County, our form of harm reduction equals a positive change. So it doesn't necessarily mean a needle exchange or anything like that, but any type of positive change. Narcan, people will say, is an enabler. Yes, it is. It enables someone to breathe. So if someone's saying, oh, we don't want to give them Narcan, it's going to enable them to keep using. No, it's going to enable them to breathe again. I've never heard someone Narcan themselves, so that's amazing if they knew the signs. But Patty and Mark are going to do our naloxone training. It will not hurt anyone if they've not been on an opioid and they are Narcan. It's not going to hurt anyone. It's not going to hurt a child. Expiration is usually 5 years after, but it actually longer if it stayed out of inclement weather. And Patty and Mark are going to do the demonstration.
Thank you.
Actually, Mark.
Hello, everybody. This is a box of Narcan. Each box of Narcan are 2 nasal sprays. They're small. I always suggest ladies put one in your purse or your handbag. No matter where you go, you always have one. This is everywhere. It doesn't pertain to just family or loved ones. If you think somebody's overdosing, the first thing you're going to do is call 911. Second thing, you're going to look at their lips, their fingertips. If they turn blue, they turn gray, you know they're overdosing. An overdose is going to stop communication from the brain to the lungs. So they're starving for oxygen. We're going to lay them on their side. Here's what it looks like out of the packet. Pop the lid off, stick it in the nose, you press the red plunger. Throw it away. Still get more. Lay them on a fetal position on the side in case they asphyxiate. Of course, you're not alone. You already got somebody or yourself on 911. So if they're not responsive in 2 to 3 minutes, you got to give it time to go through the pleasure center of the brain to unstick what we call the opioid overdose. Okay? If they're not responsive in that time, the EMTs haven't shown up yet, give them a second dosage. Doesn't matter what nostril, it's a Y. It goes to the same place. In the past, we've heard from like state troopers and stuff like that. Most times they go use one of these or a box. Now we're hearing 2, 3, 4 boxes. Depends on the strain of fentanyl. Depends on how much it ingested. There's a lot of other things going on. One of the other things that we do is we put ourselves in a glass house. I don't want to touch them. I might get it on me. It's not porous. Unless you have an open wound, a cut, or anything like that, or you wipe it on your sleeves and you do this later and it goes into another orifice, then yes, you have that possibility of having fentanyl. So I always suggest, when you put yourself in a glass house, wash your hands. We give it to law enforcement, especially to the canine units, so it's on dogs and cats. You never really realize, but when they go noses, they go in the cars, they're the first ones that are on the scene. So when they ingest it, we always make sure that the canine units have at least 3 boxes for themselves. As for, for civilians as well. Now, the individual has a choice after, if they are safe, whether they want to go to the hospital or not. It's always highly suggested that they need to have medical attention because they can re-overdose within 30 to 90 minutes. These right here, they do for minimum 10 years. Minimum 10 years. It's on the box. Provided that you have them like in your purse or you're in and out with it, like a go bag or something like that, in the office. If you have them in your vehicles, they're temperamental with temperatures. Nothing below 40, nothing below or above 104. They still work. They just lose potency. Most of the officers who do them, they either carry what they can besides all the other gear that they have. Some wives have put an extra pocket on their vest. Everything else is in the go bag.
So did I hear you say that you can use more than 2? When I was trained years ago, I was told don't ever use more than 2. So with the new strains?
Sometimes, like I said, there's 2 in a box. Sometimes the officers will tell us to use 4. We actually had a member that was on our team. 6 boxes, which is 12 hits. You got to give them that 2 to 3 minute window. It's got to have time to penetrate, sink in, and detach. You know, and sometimes one dosage, like the Narcan, is not going to do it. You know, it might take 2, it might take 4, 6. It all pertains to, the individual and how much fentanyl is actually in the system. So they say that a granule of salt is more than a fentanyl to stop the clot.
It's hoping that people are waiting the 2 to 3 minutes. I think that's the biggest thing when we see multiple doses, is not waiting. There are 2 other products out we do at the health department, we have a product called Cloxato. It's the 8 milligram of naloxone. It's the same packaging, it's just a different manufacturer, but it's 8 milligrams in each. Actually, Emergent just bought the company that created Cloxato. So now Emergent, who does naloxone and does Narcan, now owns the company that does Cloxato, which is the 8 milligram. They brought that out. They felt a high dose of naloxone was probably beneficial. I know there's a lot of controversy as far as respiratory issues. It just depends on, there's so much research going all different directions as far as this. There's also a product on the market called Nalmefene. Nalmefene is 2.5 milligram. It's a company called OpV. It's a lower dose, but the longevity of it goes 11 hours, which means it will last 11 hours in their system before it goes out with a possible overdose. There's still a lot of research out on that. So as a county, we're staying with the 4 mg and the 8 mg of naloxone. It seems, we're noticing in Joliet Police Department, they're carrying the higher dose. Overdose deaths have gone down, reversals are leveling off, but they're using the Cloxato, and 1 dose has been working. So it's breaking through that fentanyl.
And for those individuals in the community who might be interested in getting some Narcan, I believe we're going to have some at the Village, and we'll also have some at Beyond Healing, so feel free to stop by. Beyond Healing is at the Old Village Center, 14933 South Founders Crossing. So between both places, it should be available for the community.
And then I know if you walk into any Symetria, we will also give you boxes.
And we've been, during when weather's permitted, I know Homer, we have micro pantries, and a micro pantry is an anonymous place where someone would get food anonymously. We've been leaving information in micro pantries, just so someone can grab it, leave it, there's no questions asked, it keeps their anonymity. And also, we have leave behind cards, which has our phone number. Actually, it's my phone number, and I need to learn to bring my phone. But yes, it's my phone. And we have a program called Naloxone Plus, and we've been working with our police departments. We've really been working really hard with our police departments because they have to see possibly the same person overdose probably 3 or 4 times that week. We have a program called Naloxone Plus. Well, they'll call me, hey Connie, we have Joe, this is his 3rd time overdosing, he really wants help. We'll get a person out there with lived experience within 24 hours to bring them another box of naloxone and resources to get them to treatment. Because like I said, it's a small window when someone says they want help. We try and grasp into that window and get them the help they need, and also follow up with them. If they decide no, we'll still try and follow up with them. So we've been really working hard with Joliet Police Department, Lockport, New Lenox, Manhattan, Braidwood, Beecher, all throughout our county to try and get this program out there to help someone, because it's frustrating when you see someone overdose multiple times, and we want to try and get that pressure off the police department to try and get them assistance.
Do you know if it's in the schools?
It is, because last year in 2024, in January, all schools based on the state were required to have Narcan, not just in the nurse's office, but all around campus. We've done education into the schools, so that was a huge thing, was to have it on campus, not just in the nurse's office. Everyone should have it in their AEDs. That was another. So if you have an AED in your company, it should be in there as well. CPR training, Narcan training should all go together now.
Okay, great. Thank you so much. We have 5 minutes left. I think there was another question from the audience. I just want to make sure I'm not missing any.
I'll come back to you another day. A long form question. I also just want to thank you all for being here and thank the committee for having this committee. I had no idea that our community had all these resources in our community. It's very heartening to be made aware of it. So thank you all for your expertise and your time.
Thank you. It's exciting to see how home is growing, and just some of the things that we have on the horizon with this committee that we'd like to do in the future. So I'd like to thank all of our panelists for being here. Are there any final words that you would like to say, or?
I would like to thank the Village of Homer Glen, because they've been very welcoming to us as the health department, to invite us here, to always be welcoming to Narcan. Homer Glen is not a village that says not in my backyard. I think they've been very open to allowing us to come in and give us education. So thank you to the village for having us, and having us from the health department.
Yeah, just on behalf of the village, I thank you all very much for doing this. It's important for the community. I can't thank you all enough. And it's our objective here to get these resources out there for the residents so they're aware of it. As you can see, there probably is a stigma by the lack of residents that came here today. But I'm hopeful that through them seeing this and us pushing it out a little bit more, we'll be at Homer Fest, we're looking at maybe a 5K down the road, those types of things that could bring it out and make it more visible and get people the help they need. So thank you very much.
And we also have, we're trying to do like a check us out days, so that whether you're a provider, member of the community, just, sometimes people feel like they have to have a reason to walk into somebody's door to be able to get help. So we're trying to make it where you could just drop in. And if you just want to check us out and see what we have to offer, and, whether it's applicable to you or your provider or your family member or someone else, just to be able to drop in and not have to have a reason to have to drop in.
Okay, well, if there's nothing else, I want to thank you all for being here. And again, my heartfelt thanks to the panelists. Thank you very much.